Welcome to Raw Online. Today we have a very interesting trial, that a Florali trial. Okay, so as a student, when I was going through this trial showed me some shocking results. Okay, let us see what is that shocking results with respect to Florali trial. Okay, very important trial. You need to know this as an intensivist and an emergency physician. So this is a high flow oxygen through nasal cannula and acute hypoxemic respiratory failure. Okay, so this was presented in NEJM in May 17, 2015. Okay, so NEJM is one of the big journal which has a very good impact factor. And this question was asked in DNB Emergency Medicine year 2020, paper 4, question 2, Florali trial. Okay, so every trial we are going to present in Raw Online, there will be a clinical question. Okay, you need to see whether this question is proper for your clinical scenario. Okay, is this question interesting for you, right? Can you apply this question in clinical practice, or whether this trial answers a question of your clinical practice. Okay, so let us see. In patients with acute hypoxemic respiratory failure, okay, type 1 respiratory failure, not type 2, it's type 1. That's high flow oxygen through nasal cannula, HFNC, we call this HFNC, HFNC, okay. Compared with the standard oxygen delivered through a face mask or NIV, that's called as non-invasive positive pressure ventilation, can prevent intubation or not. Okay, so meaning in type 1 respiratory failure, if I put HFNC instead of placing in face mask or NIV, can I prevent intubation? That is the question. Okay, I think it's a fair enough clinical relevance, right? So we'll go with that. So now we need to see whether this is properly designed, and am I okay with the comparative statistics between these two? Is the outcome good, and is the outcome meaningful, and what is the strength, what is the weakness, and will I be applying this in my clinical practice? So this is how you need to see the trial. Okay, not just the question is there and the answer you get, you need not apply it in a clinical practice. You need to know what is the inclusion, exclusion criteria, whether the trial was designed properly, conducted properly, right? So now what is the design? It's multi-center. To start with, it's better, right? So multi-center study. It's not like one individual center, not one individual hospital. It's a multi-center study. So external validity is going to be very high. External validation is going to be very high. Open label trial, obviously. So what is open label? It is just opposite of double blinded. Okay. Open label is both the patient and the clinician know what the treatment the patient is getting. Okay. Obviously, when you see a patient in HFNC, you know that the patient is in HFNC, right? So we know it's an open label trial. Randomization was performed in permuted blocks of 6. What does this meaning, dear friends? Randomization performed with permuted blocks of 6. So what is this blocks of 6? Okay, this is called as a block randomization. Actually, to start with, for example, I want to conduct a study. Okay, so I want to divide my patients into group A and group B. I'm not speaking about this study, I'm just telling you in general. I want to conduct a study, so I want to classify teams into group A and group B. Okay, group A may be somewhere on medical management, and group B I want to do a surgical management. Okay, so I want around 1,000 patients to be enrolled. Say my sample size is 1,000. Okay, my sample size is somewhere 1,000. Okay, so I'm starting on January 1st, planning to end by December 31. Okay, so that is my study time, study period. Okay, so imagine that the patients are coming and the clinician or the family minus an observational study. Okay, so the clinician or the family, they preferred medical management itself for like first 100 or first 200 patients. Okay, for example, around 150 patients out of first 200, 150 patients had medical management, and around 50 patients underwent surgical management. Okay, so 150 patients in medical management and 50 patients in surgical management. Okay, so I started my study in January 1, observational study. Maybe in around 2 months time, in 2 months time, I started recruiting around 200 people, but like 150 people favored type A and only 50 people favored type B, right? So now I want to conduct an interim analysis. What is the interim analysis? Interim analysis meaning in between the study, like between the study. I'm going to stop there. I'm going to see, I'm going to compare, do the analysis and check whether I'm doing any harm things for the patient. Okay, or whether the trial drug is performing extremely well. Okay, so it means that I need to stop the study. Okay, if there is significant mortality, in a patient whom I'm giving an injection, whom I'm introducing a trial management, whom I'm introducing a trial intervention, if the mortality is very heavy, I cannot continue my study for 1 year or 2 years and then tell the world, right? I need to do an interim analysis in between the study itself, okay? I need to check whether I'm doing any harm for the patient, or I need to check whether I'm blocking any benefit of the patient, okay? So I need to check if those things are not there, if the study is safe to continue or not. That is the exact word to use. Okay, interim analysis will check whether the study is safe to continue for either team, for placebo team and the interventional team. Is it safe, or am I not blocking any benefits? Then only you can continue. So now I'm planning to do an interim analysis in my study. But to my surprise, there are 150 people in group A and only 50 people in group B. So I cannot do a proper matching, right? Sometimes you may even see around 190 patients in team A and only 10 patients in team B. So how are you going to do an interim analysis? It's completely impossible, right? That's meaningless to do an interim analysis comparing 190 patients with 10 people, right? So that is the problem there. Okay, I'm giving you a very small numbers. Basically, studies are done in a very large number, like 20,000, 30,000 people, right? So in that case, you will have only 100 people opting for treatment A and around 20,000 people opting for treatment B. So 100 versus 20,000 is not a good comparison at all, right? So that is where this block randomization has come. Okay, so now what is block randomization? Okay, what is block randomization? In simple terms, to make you understand, is that now I'm giving a randomization of 4. Okay, block randomization of 4. For example, the first patient opted team A. This is A, this is B. The first patient opted team A. Okay, so now the second patient comes and the second patient also opts team A. Okay, so now the computer thinks this is a block of 4. It means at the end of 4, the population has to be equally divided. So automatically, the third and fourth patient, the computer or the randomization technique puts them in team B. Okay. So now at the end of 4 patients recruitment, I recruited 4 patients. I am doing a block randomization of 4. So at the end of 4 patients, if you see, it is equally managed. It's equally divided. So now I can do an interim analysis. So every multiple of 4, if you take, the patients will be equally grouped in A and B. Okay, so it will be easy for me to do an interim analysis. Okay, so this study was done with the permuted blocks of 6. So any multiples of 6 you take, like it will be like 60 patients here and 60 patients there, like that sort of. So any multiplication of 6 if you take, the team will be equally divided between A and B. The population will be equal in A and equal in B. So interim analysis can be better performed. Okay, this is called as block randomization. Okay, this is very, very important in trials. So whenever we teach you trials, we are not just teaching you trials, we are teaching you how to conduct a trial and how to read a trial and what are these kind of specifications in the trial. Okay, so next is now come back to the study. Okay, so patients were randomly assigned within 3 hours of validation of inclusion criteria into one of the 3 groups. Okay, either are you going to place this type 1 respiratory failure patients in HFNC, or like NRBM mask, non-rebreathing mask, or standard any face mask, or NIV. Okay, so within 3 hours after you identify the patient, after randomization, you are going to allot to either of the team A, B or C.